Hello, good morning, and very good welcome from the African Union headquarters, where we bring you our usual press briefing coming from the Africa CDC. And as usual, Dr. John Kengasong, the director of the Africa CDC, is here with us. And today he'll be COVID-19 situation and the Africa CDC continental response activities across the 55 member states of the African Union. He will also be touching on the status of vaccine acquisition to begin immunization across the continent in the coming months. He will also be talking about the need to encourage African citizens to continue the wearing of masks, the observing of other public health measures as the second wave of COVID-19 infections are increasing on our continent. And then obviously after that, we will follow with our usual Q&A session. And today you can join us in two of the official languages of the African Union, and we are coming to you in French and English. And you can obviously access your preferred language as usual by clicking the globe icon at the bottom of the Zoom screen. This press briefing is also coming to you on the African Union platforms, and those include Facebook, YouTube, and the AU live stream channel. When we do get to the Q&A session, please feel free to use the WhatsApp number +251 94 5502 310. Let me come back again with that one. +251 94 5502 310. Alternatively, you can join us live on this platform, or you can send in your question through the Q&A section. All right, let me now invite Dr. John Kengasong, the Africa CDC Director, to give us his briefing for today. Good morning, Dr. John, and you have the floor.
Good morning, Wayne. Greetings, colleagues and journalists, the media. It's always a pleasure to be with you during these weekly briefings. And I'll do this exactly what Wayne indicated. I would first of all start with the epidemiological update, and then we discuss some of the support activities that Africa CDC and the African Union Commission continues to provide to the continent to respond, and then conclude with remarks on the vaccine efforts across the continent. As of 9 a.m. East African time today, close to 95 million cases of COVID-19 infections have been recorded in the world, of which about 2 million deaths have occurred, unfortunately. That leads to a case fatality rate of 2.2%. On the continent of Africa, 3.3 million cases have been recorded, which accounts for 3.5% of the total cases reported globally. Of that number, 2.7 million have recovered, which represents 83% overall of the recovery. Unfortunately, we have recorded 81,000 deaths across the continent with a case fatality rate of 2.5% and accounting for 4% of deaths reported globally. On this note, I would like to comment on the numbers you just heard. Previously, when the global case fatality rate used to be 2.4%, the continental case fatality rate was around 2.2%. But now you realize that the numbers have reversed. And whereas the global case fatality rate is now 2.2%, the continental case fatality rate is 2.5%. So definitely we are seeing a higher number of deaths occurring on the continent. And I'll come back to that shortly. 5 countries are accounting for about 70% of all cases reported in Africa, including South Africa, with 41%, that is 1.3 million cases. Morocco, 14%, representing 460,000 cases. Tunisia, 6%, representing 188,000 cases. Egypt, 5%, 158,000 cases, and Ethiopia 4% with 130,000 cases. As I indicated earlier, I would like to really focus on the case fatality rate because it begins to be very worrying and concerning for all of us. The number of countries with case fatality rate higher than the global number, which I said earlier is 2.2%, continue to increase. 2 additional countries were added to this week's list for a total of 21 countries. That is 38% of countries now in Africa are reporting case fatality rates of more than the global total. And the long list of them are present here. I will not go through all of them, but maybe just cite a few of them that are really above 3%. And I'll just draw a cutoff line there. Arab Republic with 11.8%, Sudan 6.2%, Egypt 5.5%, Liberia 4.4%, 4%, Chad 3.8%, Niger 3.5%, Gambia 3.3%, Tunisia 3.1%, Eswatini 3.1%, and DR Congo 3.0%, and Zimbabwe 3.0%. Those are just numbers above the 3 cutoff points. In terms of the epidemiological trends, during the week 2 of this year, that is the week ranging between 11 and 17 of January, 207,000 new cases have been recorded, with 6,100 new deaths reported. Represents a slight decrease of about 7% compared to last week, but a 10% increase in deaths over the previous week, which we are calling week 1 of 2021. The highest proportion of new cases reported for the week was from Southern Africa, 66%, followed by North Africa, 19%, West Africa, 9%, East Africa, 4%, and Central Africa, 2%. 5 countries are reporting the highest number of new cases, including South Africa with 100,000 new cases, Tunisia 19,000, Nigeria 11,000, Zambia 9,000, and Morocco 7,000. If you now look at the 4 weeks trends over the epidemiologic week between December 22 and January 17, and this is important because we are tracking the changes in the occurrence of new cases, especially during the festivity period and after the festivity period. We notice that an overall increase of 14% has been recorded, that is of new cases. And on average, by region, we have 25% increase over the last 4 weeks in Central Africa, a 10% decrease, again, I emphasize decrease in East Africa, 1% increase in Northern Africa, 22% increase in Southern Africa, and similarly, that is 22% increase in West Africa. Again, over the same time period, if we look at some of our most populous countries, Nigeria has recorded a 23% increase in new cases over the 4-week period. Ethiopia, 2% decrease over that same period. Egypt, 20% increase. DRC, 13% increase. And South Africa, 17% increase. Kenya continues to record a downward trend with 14% average decrease over the last 4 weeks. So that is some good news there in Kenya. Now, with respect to deaths, Nigeria over the last 4 weeks has recorded 49% average increase in number of deaths. Ethiopia, 4% average decrease. Egypt, 28% average increase. DRC, 2% average decrease. South Africa, 30% average increase, and Kenya, 11% average decrease. In terms of testing, as a continent, we are now tested close to 30 million tests. To be very specific, 29.3 million tests. And we continue to now adjust our community of practice support and training to accommodate training on vaccines, on access to vaccines and distribution on the continent. So such trainings have already started. We also are conducting trainings and supporting member states to conduct mortality surveillance across member states so that we know exactly how many people are dying and count them accurately to the best we can. Some good news here. We just this week received supplies, that is response supplies to COVID, excuse me, through UNICEF, worth $24 million that we have procured. And the supplies include 4 million masks, 2 million surgical gowns, 200,000 face shields, 2.5 million gloves, 700 oxygen concentrators, oxygen delivery equipment, 1 million COVID tests, and other clinical lab supplies. And these are all materials that we will be distributing to member states to support them to fight the second wave of the pandemic. We continue to be very grateful to our partners, and more recently, the Rockefeller Foundation has joined the fight against COVID with us, and with a contribution of $12 million to expand the coverage of testing and strengthen our ability to respond. Lastly, let me just conclude on the vaccine piece. So following the announcement of the 270 million doses of vaccines that was made last week by President Ramaphosa, I'm pleased to announce that the pre-order process has started with member states. I think several member states, I can't give you the exact number because they keep changing, now engaged with a platform that is the African Medical Supply Platform to place the orders. And as I indicated earlier, we've started training to engage with a community, with healthcare workers, so that they can actually understand how to administer the vaccines. There are a couple of things that I would like to conclude with. That it's very clear that the narrative that vaccines require ultra chains and we don't have them on the continent is, in my view, not accurate. Of the vaccines that we know that are out there, 2 of them, that is the Moderna vaccine, which, by the way, is restricted to the United States and requires a minus 20 degrees Celsius. The Pfizer vaccine requires a minus 70 degrees Celsius. So if one was to make available the Pfizer vaccine to me and said, administer it in Ethiopia, what will I do? I mean, I'll do the simple things, but all we need to do is to get the vaccines to the port, the airport in Addis Ababa. And Ethiopian Airlines, Kenya Airlines, and others are now equipped to transport vaccines at with ultra cold chain requirements. Then from there, the second thing we do is to create a vaccination coordinating unit at the Ethiopian Public Health Institute, where they already have cold chains there. They have series of -70s there. They can a nitrogen liquid problem. So I take my vaccines from the airport, store them at the EPHI, the Ethiopian Public Health Institute. The third thing we need to do now will be to create vaccination points across Addis Ababa, which means you put in 1 or 2 deep freezers across these vaccination points, say about 10 of them, around 10 hospitals or clinics in Addis Ababa. And each of that, the -70 will cost you about $15,000. So that is very, very doable. The fourth thing we do is to train healthcare workers around them. So you train about 20 healthcare workers, people that take records, secretaries that track things, put in a good information system, paper-based or electronic, and then train people how to provide the injection with the supplies. That is the needles, the cotton, and the swabs there. You have the record of who comes in to get the vaccine. And lastly, I'll mobilize the community and talk to the community and improve community literacy on vaccines and vaccination. If you do those 5 things, you are ready to use even the most complex vaccine and start immunizing a city like Addis Ababa, where over 60% of the infections are in Ethiopia. So if we do that, then you begin to break the backbone of the infection across a country of 100 and so million by starting up in Addis Ababa. So I just wanted to go through this process very carefully so that we have a common understanding of what it is. So if I do that, it will take me about 2 months or so to achieve 60% of my immunization in a city of 5 million like Addis Ababa. By the time we finish doing that, new versions of vaccines will arrive where it will require less stringent conditions, like the AstraZeneca vaccine, and then we can roll it out to other parts of the country. So I just wanted to be very clear that we at the Africa CDC believe that we are ready to roll this out. We just need the appropriate delivery of the vaccines. Countries must do what they have to do. We have developed guidelines, Africa CDC, to guide countries on to do exactly what I just explained. We are working very closely with the World Health Organization to be sure that we align and coordinate our efforts as much as possible. So I think on that, I will also like to say that to conclude that one of our major priorities now, given the alarming rate of infections going on across the continent, especially the death rates, we need to protect our healthcare workers as much as possible. So our greatest priority now is to make sure that we access enough doses of vaccines to cover our healthcare workers so that we can protect that frontline workers. So that is as a subset of the initiative of the 270 million doses there. I think we'll be really looking at how much can we acquire quickly so that in the coming weeks, we should be able to start that vaccination exercise for our healthcare workers. As a continent, we have about 3 million healthcare workers across the continent. And if we strive to vaccinate all of them as soon as possible, it would really protect them and not just protect them against COVID, but also protect our health system, because that is our greatest concern, is that healthcare workers will be infected, many will die, and then we also have a burden of HIV disease, TB, malaria, and other diseases out there that will be neglected and will further compound the problem. So that specific intervention is a top priority for all of us. Thank you, Wayne.
Thank you very much, John, for that briefing. And we move straight into the questions. The first one is coming from Coletta Wanjohi, and she's with FSN. Coletta says, the issue of equitable distribution continues to raise concern, with the WHO reiterating recently on the need for developed countries to be fair to developing countries. Do you think that there is any hope in us actually enjoying equitable distribution of the vaccines in the near future?
I remain optimistic that all our efforts collectively, that is the developed world and the developing countries, will lead us to the right direction. and the right direction, meaning equitable access. We have said this many times, and that it will be a terrible mistake that there's the gap that because of COVID vaccine, it further exacerbate the gaps, the inequities that exist between the developed countries and developing countries in terms of access to care. I think no one wants to see that. No one wants to see tensions between the developed world and the developing countries established because of a lack of equitable and timely access to vaccines. No one wants to see distrust established between the developed world and the developing countries because of lack of access to vaccines or equitable access to vaccines. I think I remain very hopeful that we will come to a common place. I think we are making some very positive steps, and our leadership, the leadership of the continent through the office of President Cyril Ramaphosa as the chair of the African Union, through His Excellency Musa Faki as the chair of the African Union Commission, are all working day and night to make sure that we get timely access and equitable access to vaccines on the continent.
Thank you very much. The next question is coming from our WhatsApp platform, and this one is coming from Saki Leguyo, and she says, can you explain a little bit more about the announcement made yesterday on the pre-ordering of the COVID-19 vaccines on the African Medical Supplies platform? What are member states expected to do, and what would be the role of the media in this?
So it's a very good question. I mean, what we have done is issue a note verbal, which is a formal communication from the African Union to all member states, explaining the process and then attaching the forms, the right forms that countries will need to fill to make in their requests. I think that is extremely important. The process is not, we've done this exercise before when we established the platform early last year, where to support diagnostics and other personal protective equipment, countries are used to, they have their access code and they have the projected number of their own allocations on the platform. So I think they are used to using the platform. It's the same formula as we use for the PPEs and diagnostics there. So that much is covered. With respect to the media, the key question is really, or the key area of need for your support is continue to engage the countries and let them place their orders, because it is based on those orders that we'll be able to arrange for the deliveries and the financial arrangements there. So again, that is a role for the media. The media also has an important role to continue to work with us, as you've done over the last close to 1 year, to make sure that the public understands that these vaccines are safe, they are efficacious. As I indicated the other week before the holidays, that we conducted a perception survey across 15 countries in Africa, covering 15,000 participants. And the acceptance rate ranged from about 60% to 90%. So again, that is an area of collaboration and cooperation between us, the media, us in public health and the media, to continue to make sure that we get to as highest level possible for acceptance of the vaccines as they begin to get to the country. So if there are other areas of partnership and cooperation with the media, please let us know. We'll be happy to explore this. This is a pandemic that will require all facets of our community, what I call the whole of society approach to fight and win the battle against this pandemic.
All right, the next question is coming from Cara Anna from Associated Press. Thank you for the briefing. Are member states telling you that they cannot afford ultra cold freezers, and what outside money is
Hello. Can James step in? Can someone from our side step in, please, while Wayne is coming on?
Morning. I'm James. I will just continue with the questions. Now, I see a question on the Q&A box, and it says, what is the reason for the high case fatality rate in Africa compared to the rest of the world? Is it about new variants of the virus? Are healthcare systems on the continent worse than in other parts of the world? Or is it simply because fewer cases are registered through testing?
So let me, first of all, try to answer Kara Anna's question. And it was about a country having the cold chain, the ultra cold chain, and requesting for support. Yes, the Gavi or COVAX has started sending out support, that is providing financial support to countries to enable them equip themselves in this. I would not encourage countries now to go out and start putting cold chain, ultra cold chains. I mean, I underline that. That is, by definition, those cold chains that require -20 and -70s across entire countries there. That would not be strategic and would not be prudent. I would encourage that based on the vaccine that will be, that countries will be acquiring through the platform, you plan accordingly, or through COVAX, you plan accordingly. So just generally putting in -70s and 20s across a country is not the thing I would do. Again, I'll repeat what I said. We should use a phased approach where you start with capital cities and you can equip them with ultra cold chains, and then subsequently, and then drive the population towards those vaccination centers. And then subsequently, as new versions of vaccines emerge, we take it to, we spread it across the entire country there. And with those vaccines that will require maybe a 4 degrees to 8 degree refrigeration. I think that is that would be my advice there. So countries, partners are beginning to support. Remember, the World Bank has put in some allocations there to support countries to prepare for the vaccination. So I think that is all ongoing in a concordant manner. So with respect to the fatality rate, I think it is very obvious that if you get more infections, you get more case fatality. Then the other factor contributing to this is that is really a need to have access to oxygen across the board, which is becoming a critical need across the entire continent. Huge critical need. That is an area of partnership that we want. And I'm through this making an appeal to all our partners across the continent that we should join forces with the Africa CDC to improve access to oxygen across all member states, because that is a key element that can be a game changer in managing a COVID-infected patient.
Thank you very much, Dr. John, for that. And colleagues, can I just remind you that we are now coming through in Portuguese as well. So that means we are now coming through to you in English, in French, and in Portuguese. So our next question is coming from Peter Mwai, and Peter is with the BBC. He says, Dr. Nkengasong, you have talked about countries with case fatality rates above the global average in Africa rising over time. What would you say is behind this?
What could I say is the what?
What would you say is the reason for countries in Africa recording case fatality rates above the global average?
Yeah, so that is what I just explained, Peter, that, I mean, if you see more cases, increase in number of cases would directly mean that you are stressing the health care system. And then it also means you're overwhelming the ability for nurses, doctors to manage patients. And because of that, there will be inadequate attention and care to those appropriately to patients, because we have limited beds, limited supplies. I also just stated that oxygen is in huge need. I mean, we need huge supplies of oxygen just to support the case management of cases of COVID across the continent. It is not necessarily due to the new variant. It's just that our systems are overwhelmed. And the other day, I heard the director of the Nigeria CDC, Dr. Chikwe, saying that, I mean, certain hospitals are overwhelmed to the extent that they have to now decide which patients to manage and which ones not to manage. So again, the crisis is here. The second wave is here with vengeance, and our systems are beginning to be overwhelmed.
Thank you very much for that. Let's go now to Sarah Jeving, and she's with DEVEX. She says, with the batch of figures that you just mentioned on mortality rates, is this the first time that the mortality rate for the continent has passed that of the global mortality rate? Or have you seen this in previous cases?
No, during the first wave of the pandemic, we were always, our mortality, case fatality rate was always around 2.2%, whereas the global total was around 2.4%. So during the second wave, we have begun to see that reverse. So I think that is one remarkable characteristics of this second wave, and which we must fight hard to make sure that it doesn't extend. I just read you, not all the 21 countries, but some that are recording a more than 3.0 case fatality rate across the continent. So it's a serious issue. I mean, it's something we are taking very, very seriously, and it will constitute a major component of of fighting the second wave in terms of strategy.
Thank you. We have someone who is coming to us online, and that is Elizabeth Merab. Elizabeth, good morning. Please introduce yourself and go ahead with your question.
Thank you, Wayne. My name is Elizabeth Merab. I am a Kenyan journalist with Nation Media Group. My question to the director is about supply and preparation of countries to deploy these vaccines. In the course of the week, the Director General of WHO mentioned that there could be delays in supplies thanks to the purchase done by richer countries. Do you still maintain that the April deadline, or rather the expectation to get the vaccines in April, is still on course? And number two, where are our countries in their preparations to receive and distribute these vaccines? Thank you.
So thank you, Elizabeth. Thank you, Elizabeth. Yes, we are still sticking with the April deadline. I think let's stick with that. And this doesn't mean that we have to wait until April. I'm very optimistic that the work that we are doing through the Africa CDC and AVAC, the work that COVAX is doing. And I must say at this point that we are working very, very closely with AVAC. I mean, having almost weekly calls with AVAC would ultimately lead to perhaps some early breakthroughs or delivery. But let's work with April as a timeline. There's a lot of work to be done to get countries prepared. But as I said earlier, during my opening remarks, the issue of preparedness, I will submit that countries are ready. Okay, it's a question of expanding the capacity to that. And I listed this capacity that countries must have. Okay, I mean, have vaccination points, train people on how to administer to scale. What is here, the key word here is how do you vaccinate at scale, and do that quickly so that within this year and perhaps next year, we've vaccinated up to about 60% of our population there. So countries are, in my view, ready to receive vaccines. They have been ready all along. I think it is not appropriate to characterize the continent of Africa as not ready, because no country was ready for COVID. We are building the ship and riding the ship as we go. You can see the challenges that countries, that developed countries like United States are facing, in the European countries in scaling up of vaccines. We just have to get ourselves start the process of vaccination, and vaccination will learn from it and will scale as we move forward. But I really like the narrative to be not that we are not ready to receive vaccines. We are used to vaccinating or handling many vaccines there. I also not like the narrative to be propagated that we require cold chains, ultra cold chains across. Yes, we require cold chain. That is a cold chain meaning to maintain vaccines at 2 degrees to 4 degrees to 8 degrees, but we don't need -80s and -70s across, say, a country like Kenya all over. That would not be the best allocation of our needs. We need -80s at appropriate points, say, in capital cities like Nairobi, Mombasa, Kisumu, but it should be based on if Kenya has ordered those vaccines that required -70. And at this point, it is the Pfizer vaccine.
There is a question coming from Samuel Buri, and Samuel says, is AVAT also trying to secure vaccines from China and or from Russia? And are there any ongoing negotiations in that regard?
There are ongoing talks, not necessarily negotiations, which means we have engaged with them, especially the Russians, just last week, and to understand what the vaccine is. And I think the action item from those talks was that they would send us their documentation so that we can see the details on the safety studies that have been conducted, as well as the efficacious studies there. We've also engaged with the Chinese, meaning that officially communicated with them and to get talks begin. So we first talk, then we can talk, after we talk, we can talk of deals that are going on. But for now, we don't have any deals with those, but the talks are ongoing.
All right, we have a question coming from our WhatsApp group, and it's from Peter Table. And Peter says, what are the ingredients in COVID-19 vaccines? You have said that vaccines are safe and efficacious, but what is actually in those vaccines?
So the question, just to be sure I understand the question, what is?
Yeah, what is in the COVID-19 vaccines?
So
what are the ingredients?
Okay, yeah. So it's a very interesting, a good question, and a very interesting question. There's several ways in which you design a vaccine. And take it from me that I'm a virologist for close to 3 decades here. So, and I used to work on HIV vaccines. So, I mean, the principle of behind a vaccine is that you want to train your white blood cells, what you call the immune system, so that they can recognize a foreign pathogen. In this case, the foreign pathogen or virus is COVID, right? So that is the foreign bird. So you have to prepare. It's like your army. You have to mobilize your army, stimulate them so that they are all ready to, and train them. So what these vaccines are doing is they are training your white blood cells, okay, your immune system, so that they are ready. The day you are exposed to this virus, they can immediately move into action and then defeat the virus. That is the principle. So how do you train them? There are several ways that you can train your immune system or white blood cells. First of all, is that you synthesize. Again, keyword here is synthesize. You synthesize the proteins that are similar to that of the virus. These are proteins, not the virus, okay? And then you use that to activate or to sensitize the immune system. So the vaccines that you have received or I have received, let me use myself for as an example, vaccines in all the vaccines we have used when we were growing up are all based on those kind of principles. Okay, they call it protein subunits vaccines, so that they are proteins that you design it based on what you see, what you learn from the virus. I think that is one thing that you should expect in the vaccines, mainly such a design. Now, in order to deliver the vaccine into the human body, you need the vaccine to be carried. You need a carrier, okay, to take the vaccine into your immune system. So what we typically would do is to build that onto an existing virus, like you call it adenoviruses. The adenoviruses are the ones that they circulate around here. They give you common cold and every day. So you build that little piece of protein that you have into such vaccines, so that in such viruses, so that they can now carry that into your immune system and challenge your immune system. So once your immune system has seen that, okay, then they are ready. The day you are exposed to a real virus, they move with full speed to attack that virus and then kill the virus. That's what is in those vaccines there. Second new technology you are hearing now is the messenger RNA vaccines, okay? How is this different from the first one? The first one that I described is that you actually synthesize the protein or the peptide. But this one, you don't do that, but you mimic the messenger RNA. You create an artificial messenger RNA that will express the protein for you. So you are still going to express the protein, but you let a messenger RNA, which is a single strand of the genetic material from the virus, which is synthesized, express the protein for you. So that is what is in those vaccines. So it's nothing different from what you and I have received over the years. I think if we are alive, it's because we have received so many vaccines there. I mean, yellow fever vaccines, tetanus vaccines, polio vaccines, measles vaccines, I mean, you name it. Okay, meningitis and all. I mean, and so it's really not different from that.
Thank you very much for that. Let's move on now. We have a question coming from Karina Marx. And Karina says, once we get the vaccine in Africa, will we need to continue observing public health measures even after receiving all the required doses?
Yeah, that is a very good question, because again, it speaks to what I've been saying, that vaccines are not going to be a magic bullet, which means that once you get a vaccine shot on your arm, you are good to go. And I mean, no, let me just be very clear. Vaccines protect, the current vaccines will protect against developing disease, but would not necessarily protect against infection. You never know that you were infected. Anyway, so because we are learning, I mean, we don't know if you're still infected, you can transmit the virus. You'll be infected, it doesn't mean you'll be sick because you have received your vaccine. And remember what I just explained earlier. If you're infected after vaccination, your immune system scrambles, they knock off the virus, you don't even know that you were infected. You don't even have a fever, a cough, or anything there. But it doesn't stop the virus from penetrating through your nose and mouth into the question that you're asking now means, if I get that, can I transmit it? So that is what we will continue to say, that to build a community immunity, I want to stay away from the word herd immunity for now. To build that community or population immunity, so many people will need to have been vaccinated so that it creates a barrier for the virus to be transmitted. Then at that point, we'll stop using a mask and we'll continue to, life will return to normal. But until such a point that about 60 to 70% of the population is vaccinated, even with a vaccine, we'll continue to use our masks as we are doing today.
All right, coming online, we have a question from Rumbi Chakamba, and Rumbi is with DevEx. She says, can you please update us on the work that the Committee on Traditional Medicine for COVID-19 is doing? Are there any promising remedies, and have any moved to the clinical trial phase since the establishment of the committee? And lastly, Rumbi says, looking at where we are now in terms of vaccines, are traditional medicines for COVID-19 still a viable option for the continent?
I think so just the specific answer to that question is that no traditional medicine group has come up and approached us for a large-scale clinical trial. So the group is there, the task force is ready, and as you recall, this is a task force between the Africa CDC and the World Health Organization. So the task force is ready. Anytime anyone has a product to be tested, we work with them. We haven't seen any as we speak. Now, the purpose of that task force is also, the goal of that is not just a short-term limited to COVID vaccine, but it's really medium-term to long-term, where we really will be encouraging that groups develop, formalize the process using those protocols and standards that we've established so that we can begin to be in that space in anticipation for any new challenges there. Knowing that we have the COVID today, tomorrow it might be something else, and we'll probably need to use that approach there. It will be a missed opportunity if we do not take advantage of that and build a comprehensive system and build a relationship between the bodies, public health bodies like the Africa CDC and the WHO, and the community traditional medicine practitioners that are developing these products. So I think that work has to be continuous. But as we speak, we have not seen any products come online for trials.
Thank you. Samuel Buri has a follow-up question, and he says, why are Southern African countries, especially now, strongly hit by the second wave?
So first of all, most countries in Africa, about 70% of the countries in Africa are actually hit by the second wave, and at times very fiercely. If you listen carefully to the briefing today, it is the first time that a country like Zambia has made it into a series of the first 5 countries with the new cases reported. I know Zambia is in the Southern African part of Africa, but you see that also in Nigeria, you see that in other parts of Africa. So I think this is a virus that is transmitted by through contacts, which means if you create a space for the virus to be transmitted, it will transmit. I think movement of people, behavior of people, adherence to public health measures is key. I really want us to not have the impression that we are desperate. We see good examples are happening. Kenya consistently has shown that they are decreasing the curve over the curve. They've gone through the second wave, and they are now in the process of really decreasing consistently over the last 4 weeks, the number of new cases there. So we are not desperate. What we should do is that determination, that sacrifice to continue to implement public health measures. Avoid congregation into avoid congregations, avoid being in close areas with people that you don't know or who are not masking. Mask as much as possible, and then of course hand hygiene. If we do those things, it will all come together, and I'm sure that what Kenya is doing is something that many other countries can do, or what Ethiopia is doing is things that many other countries should be able to do.
All right, we have a question coming from Maggie Fick from Reuters. She says, my question, do you have a direct response to the question of how many African nations are able to meet the requirements to receive the vaccines now? So this is one part of the question. And then she goes on to say, is there anything further that you want to say on exactly what those requirements are?
So the direct answer to that is all African countries, all 55 of them, can receive any vaccine now, as we speak today. I think that's the direct answer to that question. So if you take even I don't know, any country, take any country of your choice. I mean, do they have, what do you need to have a -70 there? You need to buy it, and okay, it's also on the platform, on the ASMP platform. You can buy it, it costs about $15,000. Do you have electricity in somewhere in the capital city? Yes. Do you have a hospital that you can put it there? Yes. So, I mean, can you train people to administer the vaccines? Yes. There are training tools that are available for that. Can you buy needles, alcohols, and that will be supplementary to administering the vaccine? Yes. So by that definition, all countries are available are capable of starting today, now, to vaccinate people. Again, the approach we are recommending is very important. If you get the most complex vaccine, like the Pfizer vaccine, you start with at your capital cities. And the beauty of that also is that is where most of your infections are. 60% of infections in Ethiopia are in Addis Ababa. So if you start there, that is a very good strategy where you can actually have a huge impact on the virus if you start on the pandemic, if you start doing that in Addis Ababa. So I think the answer to that is absolutely yes. You can start the vaccination anytime if you have the vaccines. So the second part of the question, I don't think I recall what that was.
The second part was asking you on any other information that you might have on that same issue.
I think that I've given you the answer to the first part, and I've also defined, I believe, extensively everything that needs to be done to get started.
All right. Okay. No, thank you very much, Dr. John Kengasong. I think that was our last question for today. I'm not seeing any more questions coming in. So this is the time for you to give us just a quick roundup of the main points that you want people to take away from today's briefing.
So thank you, Wayne. And again, let me reiterate really my appreciation to the media, the colleagues that work with us every Thursday on this platform. There are only two things I like to leave this conversation with. One is we are in dire need to have partnerships to deliver oxygen across the continent. This is critical. This is urgent for us to develop that partnership, very similar to the kind of partnership that we developed when we were in acute need of diagnostics. We are in critical need of that, and we need all support partnerships across the world to work with us to deliver oxygen rapidly to our patients in Africa as part of our strategy to respond to the second wave. The second thing is really what I outlined, that we should really have a common understanding of what preparedness for vaccines means. We are not underestimating what it needs to vaccinate as care, but the way we should really focus is how do we get started, okay? And we've outlined what is required there about the 5 key things that are required to get us started there. That is, you have vaccination centers, train healthcare workers, have the accessory supplies, mobilize the community, and make sure that we have good information systems that will track people, because remember that most of these vaccines are 2 doses. You require that you get immunized with the first dose and come back after 3 weeks to 4 weeks and get your second dose there. So you really want to minimize loss to follow up on doing that. If we do those things, then I think we are ready to go. We are ready to go and move there. So this is assuming that the regulatory processes have been taken off that, and we are working as Africa CDC, the African Union Commission, the AU, NEPAD, and WHO AVARAD to establish a task force that will facilitate the regulatory issues there. I think I wanted to conclude on that because we want to be sure that we have a common understanding of what is required, at least in the community. That way, the narrative is not that we cannot vaccinate our people because we are not prepared. We are prepared to receive any vaccines as we speak now. It just depends on the strategy of vaccination and vaccinating to scale. Thank you, Win.
Thank you, John. You will have to forgive me again today because as you were responding to that question, we received another one. And this is coming from Katarina Hohi with Bloomberg. Katarina says, last week you mentioned that Guinea had started vaccinations with the Russian Sputnik 5. Do you have more information on whether this is part of a larger vaccination campaign or whether the 25 doses administered are part of a clinical trial?
No, so let me repeat what I said last week. I said for Guinea, we know that clinical trials are going on there with the Russian vaccine, and we have engaged them officially to see, to try to get more information in the spirit of the whole of Africa approach. And we are also indicated that other countries that were using the Russian vaccine, that is Morocco, Egypt, and I think Seychelles. And I think that is there. So I really don't know more about the Guinea situation since they have not responded to us. But we'll continue to engage to see what is going on. You also heard me last week and this week that we have started talks with the Russians to see the data on the efficacy and safety. They did, when we engaged with them last time, they said that they were going to publish their results, and we have not seen it in print yet. It's not to say they don't have it, it's just that we haven't just seen it. And if we see the results, we'll be happy to communicate with you as to what we have seen in those results. So for the Guinea piece, I really don't have more information on it.
Thank you very much, Dr. John. We've been on standby for a question coming from our colleague, Paul Adepoju, but it has not come in as yet. So Paul, if you still want to ask your question, please send it to that WhatsApp number, +251 945 502 310. And one of our colleagues will be able to respond to you after this press briefing. But I think that does it for today. Thank you very much, colleagues, for having joined us, and we look forward to being with you again next week on Thursday at 11 a.m. East African time. Bye-bye for now.
Bye-bye.